Um, okay, I'm going to start with osteology, starting with the os coxa or pelvic bone, and just going over some of the structures that either I saw in the PowerPoint or I just think are like generally essential. So right off the bat, most easily palpable thing I would say is going to be our anterior superior iliac spine, and we can feel that on ourselves. And we talked about this structure as a reference structure for doing lumbar punctures. Anterior superior iliac spine is going to be an attachment site for sartorius. And sartorius is going to be like the longest muscle in the body, kind of like a seat belt that goes across the anterior thigh from superior lateral to inferior medial, just across the entire anterior thigh. And that's going to attach up here at anterior superior iliac spine. And then again, around the like medial knee. And then we have our AIIS, our anterior inferior iliac spine. That's going to be this guy right here. That's going to be an attachment site for rectus femoris, which is one of our quadriceps muscles. That's going to be an extensor at the knee joint. One of four, rectus femoris, that's going to attach at anterior inferior iliac spine. I'm not necessarily saying like everything there is to be said about some of these structures, just kind of like what I feel like is like anatomically most important for like the scope of our class maybe, or just like what I would think is important. Posterior inferior iliac spine is going to be over here. And then this over here is going to be our posterior superior iliac spine. And I just want to note that like these are from Netters, and so this is a lateral view and this is a medial view. If we ever do end up back like actually in the anatomy lab and we have to like actually do an osteology tag exam inside bones, this will be a very different kind of video, but it's just like something to keep in mind how to orient yourself when looking at these images. It's not really obviously how you see them in the body. In the body, we're kind of looking at them anteriorly and posteriorly, but right now we're looking at a lateral view and a medial view of your os coxa. So that's why like posterior and anterior spines are like on the left and right of this instead of like how we would normally see them in the body. So our posterior inferior iliac spine is going to be an attachment site for the sacrotuberous ligament, and that's going to be something that's important when we talk about, I'll just go right into it, our greater sciatic notch and our lesser sciatic notch. So our greater sciatic notch, this guy right here, is a notch right now, but clinically in the body and like a living person, not just in a bone box. That greater notch and this lesser notch, lesser sciatic notch, these are going to be closed up by ligaments, and one of them is that sacrotuberous ligament that I talked about here when I just mentioned the PIIS. So our greater sciatic notch is going to be closed up by the sacrotuberous and sacrospinous ligaments. And then once that gets closed up, it's no longer really a notch. Now that we've closed it up like this with the ligament, it's now a foramen. And we have like a similar changing of terminology in the scapula. We have a suprascapular notch that gets closed over by a ligament similarly and becomes a suprascapular foramen. So again, just like kind of like important like differences in terminology. So here it's a foramen because it gets closed up, and this is again greater sciatic notch becoming greater sciatic foramen, and then a lesser sciatic notch, this guy, or if we're viewing it from over here, this guy, is going to get closed up by just the sacrospinous ligament. So greater sciatic notch was sacrospinous and sacrotuberous ligament. Lesser sciatic notch is going to be closed solely by the sacrospinous ligament. Okay, and then we're also getting to check that out here. Okay, so this lesser sciatic foramen is what the arrow is going through. And just like important structures, this is going to be everything that goes through them. But like right here, I just have that piriformis muscle. It's going to be one of our lateral or external rotators of the hip. Okay. And piriformis is going to, that's this muscle here. I have another picture. Piriformis is this guy. That's going to be one of our lateral rotators of the hip, part of Pigogo Q muscle group. And that's going to traverse the greater sciatic foramen. And then that's going to be an important reference structure for a lot of things. Piriformis is super important. Most important because it's like a great reference structure. It is the reference structure for finding the sciatic nerve in the body. So if we were in the lab and we just like had a cadaver and we were going to do this gluteal region posterior thigh dissection, we would, actually, yeah, you know what? I'll get to that later. But basically, you have to know sciatic nerve is going to emerge inferiorly to the piriformis muscle, to this inferior border of piriformis. Okay, so piriformis is a really important reference structure for the sciatic nerve, and piriformis is going to go through the greater sciatic foramen. And then other structures that go through the greater sciatic foramen, vessels basically, are going to be kind of classified as either superior suprapiriformis or inferior to the piriformis within this foramen. Okay, so here we see superior gluteal vessels, okay, are going superior, or emerging out of the greater sciatic foramen, superior to the piriformis, and then we have inferior gluteal vessels that are coming out inferior to piriformis, as well as, like I said, sciatic nerve is emerging from the greater sciatic foramen inferior to piriformis muscle. Okay, and then coming out of our lesser sciatic foramen in this image, you can see pudendal nerve, and those innervate our external genitalia, very intertwined with us experiencing pleasure, if you will, as well as the obturator internus tendon. And obturator internus tendon is also going to go through our lesser sciatic foramen, and that's another external or lateral rotator of the hip. As far as the os coxa or pelvic bone goes, I should have mentioned we have three parts. So this part that's kind of just, you know, bone color in this image, that's going to be our ilium, and the blue here is going to be our ischium, and the pink is going to be our pubis or our pubic bone. Another point is that this ischial spine is going to be this pointy guy that kind of separates the sciatic notches. And the ischial spine is an attachment for yet another lateral hip rotator, which is going to be our gemellus superior. These are all part of Pigogo Q. There's three lateral hip rotators that I've mentioned so far. We have attachments here. Okay, I think he mentioned, okay, we talk about the gluteal lines. So over here, I saw this in the slideshow. So these are these kind of ridges that on the actual bones are not always super clear to see, but they are there. You can find them. And our gluteus medius is going to kind of originate between, kind of spanning these anterior and posterior gluteal lines. So this is posterior and anterior, and that's where gluteus medius is going to originate. And then gluteus minimus is going to originate spanning between our anterior and inferior gluteal lines. So yeah, that's kind of what those ridges are showing. Those are our gluteal lines. Anything else to talk about here? All right, I'll just call it a day for that. Okay, let's talk about the femur. Okay, so I've already kind of written out some of these things. This is our head of the femur. This is going to articulate with the acetabulum, which I should have mentioned, this guy of the os coxa. Okay, so this is part of the lateral view. Okay, so this acetabulum is going to face externally or laterally and articulate with the head of the femur. Okay, and like I said, if you ever have to side bones, you know, if you ever end up back in lab or something, hit me up and we can talk siding bones. But basically, knowing that the head of the femur is what's going to articulate with our os coxa, we know that this is going to be pointing medially. So this is medial. And then, you know, that just kind of helps us also differentiate which condyles and epicondyles we're looking at, medial versus lateral. So if it's on the same side as the head of the humerus, then you know that it's going to be a medial condyle of the femur. And we also have this fovea for the ligament of the head. Okay, and so this fovea is just like a little depression, like just a little spherical, like you took the pit out of an avocado and it's what's left. Okay, that's the fovea on the head of the femur. And then I already just kind of have some these muscles that I have with these arrows pointing. That's just muscles that are attaching there. Um, so yeah, we have things like gluteal tuberosity. That's obviously going to have a gluteal attachment. That's going to be gluteus maximus. Pectineal line is going to be an insertion for the pectineus muscle, which I'm going to kind of go over in a sec. Um, yeah, this can be independent studying. Just some things. Popliteal surface. Popliteal means it's back of the knee, so we know that we're looking at our posterior surface when we see this triangular popliteal surface. Just again, important for being able to side bones if we ever have to do that. I'm going to try to kind of breeze through osteology a bit more here. Except that this tibial tuberosity, we're looking at tibia and fibula. They're kind of analogous leg structures of radius and ulna in the forearm. In the leg, we have tibia and fibula. So our tibia is our medial bone, and the fibula is the lateral one. Tibia is, as you can see, much bigger, definitely the weight-bearing bone of the leg. And we have this tibial tuberosity, and this is on the anterior surface. So again, siding bones, it's like important to kind of know where these structures are, these bony features are. So we know that if we're looking at the bone and we see the tibial tuberosity, we know that we're looking at it anteriorly. Tibial tuberosity is really important because it provides an attachment point for the patella. Okay, the patella is our knee bone via the patellar ligament. Okay, so tibial tuberosity, this guy right here. And anytime that you kind of see like a big bony prominence or protuberance like a tibial tuberosity or a tubercle, like this tubercle that we're going to talk about too in a second, that kind of bony prominence is going to grow like that as a result of higher force or stress being put on that part of the bone. And so that means that you should immediately be thinking that there are going to be muscles, probably multiple muscles or really important muscles or muscles that do a lot of work, muscles attaching there. Okay, that's going to be what causes bone to grow like that. Bone grows, and that's Wolff's law, according to like the stressors that we put on it. So the reason that these got to be tuberosities and tubercles is because they have attachments to muscles that are putting in work. That's something that you should be thinking about when you kind of are just thinking generally about bony features that you see. Tibial tuberosity, okay, is going to provide attachment point for the patella via the patellar ligament. Okay, and so this has to do, and this is really important for knee extension. And so knee extension happens with our quadriceps group. And so when we contract our quadriceps and our anterior thigh, that quadriceps tendon, I feel like I'm doing a Khan Academy video. That tendon, which we're going to be able to see a little better once I get to like the musculature, is going to attach to the patella, attaches to the patella, and then pull on the patella, which attaches via the patellar ligament to the tibial tuberosity. So it then pulls on tibial tuberosity, again via the patellar ligament. Okay, so anterior, that tibial tuberosity is really important for knee extension. Okay, and then also I saw it in the slide, and it is important, Gerdy's tubercle, which I think he called something different, but I think he did include Gerdy's tubercle too. Okay, Gerdy's tubercle is right over there, and Gerdy's tubercle is the insertion point of the IT band, which is the iliotibial tract, which is along the lateral thigh And that's all I'm going to kind of say about that. I don't really think that we've like had a lot of questions about that. So let's get into the nitty gritty now. Looking at posterior thigh, gluteal region. Okay, let's say we're in the lab. We reflect the scan. First thing we're going to see, boom, gluteus maximus, okay? If you're in the lab, and let's say we ever get to have like tag quizzes or anything again, if you're in the lab, some of these things are going to look like they could be muscles that they aren't. So it's really important to kind of like start to think about these structures in terms of other reference structures. So gluteus maximus, most superficial. Huge guy, superficial, but you'd be surprised how many people kind of get it wrong. So this gluteal aponeurosis is this, okay? And this is covering gluteus medius. Okay, it's tough. And aponeurosis, we had a bicipital aponeurosis. They're really tough. They're really tough fiber sheets, very pearlescent, collagenous, okay? A lot of collagen. They're tough. They're annoying, and they really keep the stuff in place, if you will. So we have to reflect and get through this gluteal aponeurosis before we can see, and also reflect, gluteus maximus, most likely, before we can really see our gluteus medius, okay? And so that's what we've got here. Okay, so obviously gluteus medius is cut in this image so that we can see the lateral hip flexors, but basically gluteus medius is who would be deep right here to this gluteal aponeurosis, okay? So we've peeled back our gluteus medius, excellent. And right here we got our gluteus minimus, delightful. Okay, and then we have our ptegogo Q muscles, and ptegogo Q comes from piriformis, gemellus superior, obturator internus, gemellus inferior, and then we have an obturator externus, which you can like never really see. It's deep to this stuff. That's the other O. We have P, go, okay, little fake obturator externus. And then Q is quadratus femoris. And this guy is going to insert on our quadrate tubercle, which was a structure on the femur that I think I kind of glossed over. Ptegogo Q are going to be our lateral or external hip rotators. And let's see, anything else to say about that right now? Oh, yeah, okay. Like I said, when we were talking about Ascoxa pelvic osteology, and we were talking about the greater sciatic foramen, which again is the greater sciatic notch of the ischium of the Ascoxa, once it's been closed into a foramen by the sacrotuberous and sacrospinous ligaments. This right here is that piriformis muscle that I said was running through it, and that's really important. Okay, and then what I said was really important about piriformis too at the time is that our sciatic nerve, Big Daddy sciatic, emerges inferior to the piriformis. Let me see what I've got next up here. Okay, so worth talking about just while we're talking about the gluteal region still, and then I'll get back up to talking about these posterior thigh muscles. But first, let's just talk some of these nerves. So again, this is piriformis. That's extremely easy for me to ID immediately, just because I see that sciatic nerve coming out inferiorly. Okay, and then I know that this muscle superior to that is going to be our gluteus minimus, and then I know P. Okay, you've got P, go, and then like I said, you're not really getting much of an obturator in externus, so just ignore the next O and then Q. Okay. So it's really that easy. And then I also kind of mentioned before that obturator internus, that it's tendon, this O. Obturator internus tendon is also going through the lesser sciatic foramen. Just a little callback. Yeah, okay, and then we've got superior and inferior gluteal nerves. And those will also come out within the greater sciatic foramen. Okay, superior gluteal nerves come out superior to piriformis, as we can see, and the inferior gluteal nerves are going to come out inferior to piriformis. And this is all still coming out all within that greater sciatic foramen that we were looking at before, okay? All within here, all within here. Okay, so it's important to start kind of like associating these structures with each other. Let's talk muscles. Let's get into the nitty gritty. I'm going to go through this like maybe a little more quickly because this is kind of like the easiest stuff to find videos on already, even though I know that everyone loves to hear my voice. So let's get into the posterior thigh. Posterior thigh is really easy. Okay, these are going to be our hamstring muscles. Hamstring muscles, I'm going to go from lateral to medial. So this right here, this shiny pearlescentness, that's going to indicate, right, there's going to be a lot of collagen and stuff, right? Pearlescent, strong sheath. Okay, that's our IT band. That's our iliotibial tract. Okay, and then there's going to be, do they have it in this picture? All right, we'll talk tensor fascia lata later. Tensor fascia lata is a muscle that we associate with the IT band or iliotibial tract to be anatomically proper, but I'll get to that later since it's not really seen all that well in this pic. Okay, so from lateral to medial, first thing that we're going to have, this right here is our biceps femoris. So just kind of know, okay, that our long head is going to be the one that we can see a lot better, and then our short head is peeking out over here, and it's the rest of it is laying deep to the long head. Okay, moving medially, we have semitendinosus. Okay, that's this guy, so called because he has this sick tendon. Okay, and then medial to that we have semimembranosus, and it's easy to remember which one's which, even though they have really similar names. Semimembranosus, M is medial. Okay, semimembranosus is medial to semitendinosus. And also semitendinosus has this really characteristic, awesome long tendon. Okay, and then medial to that, we have not part of the, this is not part of the hamstring group, but we can see gracilis here. That's just like medial thigh, is just the most medial muscle of the thigh. Here's gracilis on this side. Okay, again, boom, boom. And I think what I have in next is that I start talking, oh, all right. Just a little note, there's really not that much to say about veins in general, because for the most part, like the arm, they're just kind of venae comitante, or just veins that are named the same as the artery that they're running alongside. They're not really ever doing anything different than the artery that much, with the exception, very extremely important exception of our great and small saphenous veins. So this is insanely important. In the lab, we are doing the leg, right? We're dissecting the leg. It is extremely important to know the whereabouts of, in particular, your great saphenous vein, because it is so superficial and really easy to cut as you're reflecting skin with a scalpel. Okay, so when you're reflecting the skin, you're first getting in here. It's along the lateral aspect. This isn't even really a great picture for showing y'all the, oh, I meant to say, I'm so sorry. I meant to say medial if I just said lateral. It's along the medial aspect of the leg. Okay, it starts over in the foot and it's going to climb up the whole medial leg. Okay, but it's really superficial. And that's just important to note. So like you just need to be really careful as you're reflecting skin across the medial aspect of the leg and thigh, that you're really, 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 really keeping that scalpel close to the skin so that you're not going to accidentally slice through great saphenous vein and then, accidentally reflect it like with skin and fat, okay? And then we have small saphenous vein, which also is going to arise from here. Okay, that's our small saphenous. Sorry. That's our great saphenous medially. So small saphenous, you don't have to be as freaked out about. It's not going to be as superficial as great saphenous, except where it ends right here, where it drains into the popliteal vein, just like in the popliteal fossa, or just region. It's going to pop out superficially here. So, I mean, I guess this note is like really more for like lab if we ever end up in it, but just be careful of those. So let's talk about the course of the sciatic nerve first. So we have our sciatic nerve. It is coursing inferiorly, okay, after emerging inferiorly to our piriformis muscle. And it's going to travel. Okay, we're getting kind of a deeper perspective right now, so I'm just going to note that like some muscles are being pulled out of the way so we can get this glimpse. But you're not going to see this happening superficially. You're not going to see this happening right when you reflect the skin and get to, and get to this level, okay? You're going to have to pull back some of these muscles, okay? Get in between here to see it. I just wanted to make that note that this is happening deep to some of those muscles, okay? So sciatic nerve is going to split into the tibial nerve and the common fibular nerve in the popliteal region, in the popliteal fossa. Popliteal just means back of the knee, okay? And that's our tibial nerve. And tibial nerve is just kind of going to continue this course distally, pretty much along the midline of the posterior leg. It's going to innervate all of the muscles of the posterior leg, some muscles of the foot. And I just also want to kind of clarify and make sure it's clear that like arm and forearm are two distinct things. Thigh and leg are two distinct things. So when I'm talking about the leg, I specifically mean like colloquially the lower leg. If I'm talking like upper leg, I'm going to say thigh. So that just I thought needed to be said. Okay, so tibial nerve is going to do all of our muscles of the posterior leg. So we've got gastrocnemius. Okay, who we can see, who's this guy? Okay, he's got medial and lateral heads. This is the same muscle. This is all gastroc. Okay, that's going to be innervated by the tibial nerve. All the muscles of the posterior leg. Some of the muscles of the foot, it's going to do the skin of the posterolateral leg, lateral foot, and the plantar surface of the foot, so like the sole of the foot. Okay, it's going to descend all the way down there. And then the other branch that the sural nerve gives off is the common fibular nerve. So I'm just going to start kind of writing this out, okay? We've got sural nerve, okay? And then this right here, this split is happening in the popliteal region, fossa, right here, is going to give the tibial nerve and the common fibular nerve, which you will also see in some books called the common perineal. If any of your parents are physicians, or you know some older physicians, they probably use perineal instead of fibular. All right, these will both give off, each give off medial and lateral sural cutaneous nerves. It's too much to write right now. Basically, they're ultimately going to give some contributions to our sural nerve. Sural nerve is going to run alongside our small saphenous vein, along, kind of superficially along the posterior leg. Okay, those are going to come from both of those guys. Common fibular is going to, as you can kind of see here, just like immediately course laterally. Okay, and it's going to wrap around the fibula, unlike our tibial, which is really just continuing this course. I'm going to erase some of this because it's getting real messy. Sorry, my first time doing this. Common fibular, once it's coursing around here, is going to split into superficial and deep fibular nerves, and I'm going to talk about that more once I kind of get into the musculature of the anterior and lateral compartments of the leg. Okay, and then tibial nerve is going to stay its beautiful self. Okay, it's gonna. This is the common fibular nerve terminating, by the way. Okay, this is just a branch. Okay, it's going to give off that sural nerve, or give off medial sural cutaneous. It's going to end up contributing to the sural nerve. That we'll kind of see around here ultimately. Hopefully, I have a picture of that. Okay, tibial nerve is going to end up going through the tarsal tunnel, which I'm sure you can guess is just analogous to our carpal tunnel. Okay, we've got flexor and extensor retinaculums, except we've got superior and inferior ones, but it's basically kind of like the same concept. Okay, this is going to pass through the tarsal tunnel, or tibial nerve. and it's going to give off sensory branches on the foot. Plantar surface of the foot. All right. I should also just kind of mention our sural nerve. Our sural nerve is running through the gluteal region, but it's not innervating any of those muscles. That's going to be like the superior and inferior gluteal nerves more so. Okay. But the sural nerve is going to directly innervate the posterior thigh muscles, these guys, and also the hamstring portion of adductor magnus, which is a big boy muscle that I'm going to get into a bit more shortly. Um, and then obviously it's going to give off these, which of course do the like rest of the leg. Common fibular, these are going to end up innervating anterior and lateral compartments of the leg, the remaining foot muscles that the tibial nerve doesn't get to. Okay, as well as it's going to supply common fibular, right? We're going to supply skin of the lateral leg and the dorsum of the foot. Okay, so this does sensory to plantar surface. Okay, and this is going to be to our dorsal surface. Dorsal surface of the foot, sensory. And this is going to be plantar sensory. Okay. Here's a nice picture that kind of shows us from a superficial view of what our common fibular nerve is doing. So remember, it's arising from that popliteal fossa, and it's wrapping around the fibula. It's coming around, and it's going to split into superficial and deep. And here we can see our lovely superficial fibular nerve, and I'm going to talk more about where we can expect to find that once I get into more detail about these muscles of the lateral compartment of the leg. I kind of forget why I put this picture here. Okay, so here, this right here is where we're seeing that common fibular split into superficial, which is this guy, superficial fibular nerve, and deep fibular nerve. Okay. And I'm going to reference this picture again after I get into the arteries, because we can see here that our deep fibular nerve is buddy-buddy with an artery. And that is significant. All right, so before we get into arteries, look at this little note I made myself. Before we get into arteries, let's just go over the anterior muscles of the thigh really quick. So we've got adductors, okay? We've got adductor longus right here. Okay, gracilis, which is the most medial muscle of the thigh, is going to help with adduction. We've also got an adductor brevis muscle, which is going to be deep here, who we can't really see, as well as adductor magnus, who is a big boy. It's super significant, and I'm going to talk more about adductor magnus, who also has kind of hamstring function. Sartorius, this lovely seatbelt, the longest muscle in the body, running across. I kind of talked about him before. This superolateral to the inferomedial. Okay, he's going to go all the way here. And sartorius is going to contribute to pes anserinus, which means goose's foot, and it's these like 3 tendons inserting on the lateral aspect of the knee. Sorry, medial aspect of the knee. Okay, that's adductors. Adductors are in yellow, but do not forget that we also have an adductor brevis and an adductor magnus. Okay, and pectineus is also kind of, pectineus also has some adductor function, but pectineus, our guy right here, I'm sorry, but pectineus is also going to be a hip flexor. Okay, and so these pink ones are hip flexors, so it's a hip flexor along with our iliacus and our sartorius. Iliacus is kind of just like spanning this whole iliac crest here, which you can't really see that well, but that's going to be a hip flexor. And then last thing that's super important to talk about here, talking anterior thigh muscles, is our quadriceps group. So I mentioned it before, and I was talking about the tibia and the tibial tuberosity, which we can see right here. and that patellar ligament, which we can see right here, and the patella, and then this quadriceps tendon. Okay, quadriceps femoris tendon. So our quadriceps femoris, as the name implies with quad, is going to be a group of 4 muscles. Okay, we got rectus femoris. That's not nice handwriting. Rectus femoris, vastus medialis, vastus lateralis, vastus intermedius. Okay, and they're all going to have a quadriceps femoris tendon that they're all becoming a part of, and then that's what I was talking about before. It's just super important for knee extension. Okay, they're all going to come together, have this kind of common tendon that's going to insert on patella, which is going to attach to tibial tuberosity of the tibia via the patellar ligament, and that is how that's how we get the movement across the knee joint. That's how we get knee extension. I will just mention, okay, all of these, and because I love a color code, all these guys are innervated by the femoral nerve. Okay. The flexor group, these guys, also by the femoral nerve. And our adductors are going to be kind of split. Okay, so adductors longus and brevis, so we can't see it in this pic because he's deep and he's not shown, and gracilis. Adductor longus, adductor brevis, and gracilis are all innervated by anterior branch of obturator nerve. Okay, and as you can guess, I don't know if you paid attention to this in the osteology, I don't think I talked about the obturator foramen in the os coxa, but yeah, obturator nerve is going to run through our obturator foramen. Obturator nerve is important. This anterior branch is going to innervate these 3 muscles. Okay, the posterior division of that nerve is going to innervate the adductor portion of our big ol' adductor magnus. And then that hamstring portion, I said that it was so big, the hamstring portion of that. And these are for adductor magnus. I'm sorry, this is so messy. Hemipart's going to be sciatic nerve. Okay. Adductor magnus is now a good time to just get right into it. No, first I'm going to talk about this here. Okay. I stole these slides from him because it's just easier than me writing it out to already have it here. So let's just talk femoral triangle real quick while we're in this region, okay? This right here, this is our femoral triangle, okay? Like he has it here, our femoral triangle, okay? So that is going to be bound by our inguinal ligament. Boom, boom, boom. Inguinal ligament's important for other stuff too, which I'm going to mention probably shortly. Okay, by our inguinal ligament. Laterally by this medial border of our sartorius muscle. Okay, and then medially by this lateral border of adductor longus. And this femoral triangle is going to contain, like it says here in a slide's navel. Okay, we're going to have the femoral nerve, femoral artery, femoral vein, empty space lymphatics. I don't really have much to say about. I don't really know what that is. Sorry. The femoral artery is super important. I'm actually so excited to get into it in just a second. But let me just make sure that first I'm not missing anything. Okay, yeah, adductor canal we should talk about. Okay, so Well, no, I'm going to get into the femoral artery. Okay, so femoral artery, I'm just going to get into the branches of this artery in general now. Femoral artery is going to, like other arteries that we've seen in the upper extremity, it's going to be called something else proximally and distally. So proximally, before it's called the femoral artery, it's our external iliac artery, okay, over here, deep to all this. It's our external iliac artery. Okay, there's our internal iliac, there's our common iliac. And after it passes deep to this inguinal ligament, that is the other, that's what I was talking about it before, okay? Inguinal ligament is also a boundary of the femoral triangle. When the external iliac artery passes deep to this ligament, it is now called the femoral artery. Femoral artery is going to pass through the femoral triangle between, right, like we said, between inguinal ligament sartorius, which is cut, that would go across like this, and adductor longus. Going to go through there, and then within this triangle, it's going to be enclosed in the femoral sheath alongside the femoral vein. Do I have a picture of that? Yes, sort of, if you look here, not really. Okay, but basically it's going to kind of have this connective tissue sheath around it. Just these two, not this guy, okay? Just these two, not this guy. Going to run through the triangle in the femoral sheath with that femoral vein. And it's going to pass through the adductor canal. And here is the first time that I've really shown you guys in this, our adductor magnus muscle. So much bigger than even this, okay? This is the one that has an adductor portion and a hamstring portion. It's so dang big. And so femoral artery, along with vein, and just assume all the same stuff for vein, basically, as I talk about the femoral artery and its branches and stuff. Just remember that the flow of blood for veins is exactly opposite for arteries. So when I say branching, for vein, it's going to be draining into instead of branching off of when I'm talking about the artery. Okay, and so it's going to go through, does it, okay, I thought it might have a little tag here, but not so much. Anyways, it's going to go through the adductor hiatus. And the adductor hiatus, do I really not have a picture of this? Whatever. Adductor hiatus is basically like this little loop that happens of the adductor magnus's tendon across the femur, basically. Okay, so it's going to go through this little loop. And I just want to see if I have a better picture of this happening. Okay, I guess not. Basically, it's going to emerge then posteriorly as the popliteal artery, okay? So once we get into the posterior knee, once it has emerged posteriorly through the adductor hiatus, it is now going to be the popliteal artery. Okay, popliteal artery is going to course through this popliteal fossa, which there are definitely some slides on, and we should definitely know the contents, but I feel like this video is taking forever, so I'm not going to go into it right now. Popliteal artery is going to go through our popliteal fossa, and it's going to do its own branch and stuff. Okay, it's going to branch into a larger anterior tibial artery. Here, I think I need to go back for this. Okay. Here's our popliteal artery and vein. Okay, and it's going to split into anterior and posterior tibial arteries. Okay, anterior tibial artery is right here. He's going to come back, as you would imagine, anteriorly, and he's going to run with that deep fibular nerve, branch of the common fibular nerve. Okay, and then the posterior tibial artery is going to run alongside our tibial nerve. Okay, and he's also going to give off fibular artery. So this branching that happens of the popliteal artery into anterior and posterior, and so we can see anterior coming off right here. This branching that happens of the popliteal artery into its first branches, which, like I said, is the anterior and posterior tibial arteries. Okay, so femoral is going to become popliteal artery. once it goes through that adductor hiatus. Okay, and then that little cherub is going to split into a anterior tibial artery and a posterior tibial artery. And you, my friend, are going to run with deep fibular nerve. And you, my friend, are going to run with tibial nerve. And that's what we're seeing here, okay? This is anterior tibial artery, posterior tibial artery, okay? And this is still posterior tibial artery. It's just giving off a little fibular artery right here, okay? But this is still posterior tibial artery continuing all the way down, posterior aspect of the leg, deep to gastrocnemius and soleus, who are going to be our more superficial muscles here, okay? Gastrocnemius and soleus, I didn't really talk that much about. They're going to have a common tendon. Distally, that's going to be your Achilles tendon. Okay, posterior tibial artery is going to run with this tibial nerve, who, like I said earlier, is going to be innervating all these muscles. Okay, here they come. There they go. And then I'm going to go back again to show where that anterior tibial artery is going. Okay, I said that he's going to be running with the deep fibular nerve. I said I was going to get back to that. Here I come. I'm sorry, this is not better organized. Okay, this is the anterior. This is the anterior compartment of the leg that we're looking at. Okay, we're pulling back some of these muscles to see our deep fibular nerve running with our anterior tibial artery. And our anterior tibial artery distally is going to be our dorsalis pedis artery. Okay, and you can take a pulse there. And then sweet dorsalis pedis is going to give off some of this stuff. I honestly don't remember. I said I wasn't going to do the foot, and I'm going to stick by that. I should maybe have done this sooner, but basically muscles of the anterior, just the leg in general. We're looking at the lateral leg, so posteriorly, this is gastroc, who I was talking about, okay? Gastroc has a medial and a lateral head, and that's going to be, that's right here, that's going to be important reference structure for that small saphenous vein and sural nerve. Ooh, can I see those anywhere? Not really so much. As well as deep to these, okay, deep to this gastroc, and soleus is just deep to it. Deep to those guys, once you reflect that, okay, here's what I said. That small saphenous vein, you can see emerging in between heads of gastroc. I don't have a better picture, okay. Basically tibial nerve deep to that is also going to kind of run in a similar fashion. So that's gastroc posteriorly. So right now we're seeing like the lateral head of gastroc. Okay. This is tibialis anterior. Okay. So you can, tibialis anterior is basically like the main muscle of the anterior compartment that you feel on yourself just lateral to your tibia or your shin, basically. So you feel your shin and you feel what's that bulky stuff, that's your tibialis anterior. And this is all enclosed, our anterior compartment, in this really tough sheath of connective tissue, okay? And it really is like really tightly binding all of these muscles in the anterior compartment. And so that's how you get anterior compartment syndrome, is that if you have any inflammation to anything in that anterior compartment, the tissue surrounding it is encasing it so tightly that it really leads to pain and stuff. So I just thought that was worth mentioning. Okay, tibialis anterior is that anterior muscle. Reference structure is that it is just lateral to your tibia. Moving laterally, we're going to have extensor digitorum longus, this guy. And I'm just going to erase all this first. Okay, extensor digitorum longus. Tibialis anterior, extensor digitorum longus. Okay, fibularis longus. And I want to mention here this very important note about superficial fibular nerve for like a lab setting is that you're always gonna find that your superficial fibular nerve is going to emerge between your extensor digitorum longus, this guy, and your fibularis longus. That is textbook. I can if you give me a body, I can find superficial fibular nerve in a second by just looking in between these muscles. Okay. Um, and then similarly, I definitely have a picture here where I show that anterior tibial artery running with deep fibular nerve. Again, deep and superficial fibular nerves come from our common fibular nerve, which came from our splitting of the sural nerve into common fibular and tibial. These are going to be found emerging deep in between tibialis anterior, which we're pulling back right here, tibialis anterior and extensor digitorum longus. Okay, so again, I can pretty quickly find these in a body. I'm literally just going to do this. I'm going to ID tibialis anterior, kind of retract it and just kind of dig my fingers in between tibialis anterior and extensor digitorum longus, proximally in the lower leg to find anterior tibial artery and deep fibular nerve. And then distally, you're going to notice that it is emerging between still tibialis anterior, except now it's between tibialis anterior and extensor hallucis longus. And I'm not going to talk too much about the action of these muscles because, like the forearm compartment, it's really self-explanatory what they're doing. Okay, hallucis is your big toe. Okay, like pollicis was your thumb. Is there anything else that I really want to say? I'm just going to call it quits. I'm just going to call it freaking quits. I'm tired, and I hope that this was helpful. I hope this wasn't like a fever dream. I'm honestly so out of it.